Okay, so we're going to talk a little bit about heparin and Coumadin now. So now I'm in Clayton, chapter 27, pages 436 to 438, in the ATI book on starting on page 291, under anticoagulants. So the hallmark drug here is heparin. You may also talk about something called low molecular weight heparin, and the most common drug there is Lovenox. So we give heparin, it's an anticoagulant. We give it to prevent clots from forming, and we give it in patients who are at high risk for forming clots. Patients who maybe have had a big surgery, maybe they've had a hip or a knee replacement, maybe they've had a big abdominal surgery, and they're going to be immobile for a while, and they're at risk for DVT. Or maybe they're in the process of having a big stroke and there's a big clot forming in their brain and we don't want the clot to get any bigger. The key thing to remember here with heparin is it doesn't dissolve a clot that's already there. It doesn't dissolve a clot. It prevents clots from forming. So it will prevent a clot from getting bigger, but it's not going to get rid of a clot that's already there. It will interrupt the clotting cascade and keep a clot from getting bigger. Running in the background there. So it doesn't it doesn't dissolve clots. It prevents clots. Labs to monitor when patients are taking heparin, we need to monitor a lab test called a partial thromboplastin time, and this monitors a patient's bleeding time. This is measured in seconds, and it basically tells us how many seconds it takes the patient's blood to clot. And we'll know that the patient's heparin is therapeutic if their PTT is 1.5 to 2 times their baseline. So a normal PTT is 60 to 80 seconds. So if the person's baseline is 60 and it comes back at 90, that's 1.5 times their baseline. So the lab numbers are going to fluctuate a lot, and basically what you're looking for is if the value is 1.5 to 2 times the person's baseline. So that's an important number to remember right here, because you may see a test question that gives you a baseline and then gives you the patient's number and asks you, is this value within normal range? And what you need to figure out is if it's 1.5 to 2 times the patient's baseline. If it is, then it's therapeutic and it's good. If it's more than 2 times the patient's baseline, then the person's at risk for heparin toxicity. And we'll talk about the dangers of heparin toxicity here in just a minute. Now, interestingly, with heparin, it must be given either subcutaneously or IV. It cannot be given PO. It gets inactivated in the digestive system, so it cannot be given PO. It has to be given either sub-Q or IV. Lovenox is given sub-Q only. Heparin can be given sub-Q or IV. Lovenox does not require frequent monitoring of those PTT levels, and heparin does. So Lovenox is good for patients who are discharged to home. They can give themselves sub-Q injections of Lovenox. So for example, maybe the patient had hip replacement surgery and is being discharged to home. They can give themselves injections of Lovenox until they get back up on their feet and resume their former levels of mobility. All right, a couple of important adverse effects. To note, it's an anticoagulant, so hemorrhage is a huge adverse effect. So some of the things that you're going to see with hemorrhage, and this is coming off of the ATI book on page 291, just so you have a reference of where I'm getting this information. Increased heart rate, the patient's going to become tachycardic, along with increased heart rate, decreased blood pressure, bleeding from the gums, bruising, petechiae. Remember, petechiae are little pinpoint bruises. They're little micro bruises in the dermis, in the layers of the skin. And black tarry stools, which is basically blood in the GI system that kind of sits in the GI system and gets bleeding in the stomach that gets digested and passed out with the stools. So black tarry stools is a bad sign. That's telling you that there's bleeding in the digestive tract. Heparin-induced thrombocytopenia. So low platelet count due to the heparin. And low platelet count, again, the patient's at risk for bleeding. If the platelet count is less than 100,000, the patient needs to have their heparin stopped. And that's a big deal because the patient's at risk for hemorrhage. And then toxicity or overdose from the heparin, which can lead to hemorrhage. The important thing to remember with this toxicity or overdose is the antidote. This is one of those things you must remember. Oops, antidote. That's a T. Sorry. I'm going to write it in red so you remember. Oop, not brown. Red. The antidote for heparin is something called protamine, to you, sulfate. So the antidote for a heparin overdose is protamine sulfate. Don't worry about how fast you give it, how many milligrams you give it. Just know that if the patient is having a toxic reaction to heparin, if they're hemorrhaging, they have an overdose to heparin, if they're at risk for overdose to heparin, be prepared to give protamine sulfate. You can guarantee if you're going to be asked about an overdose of heparin, or if the patient's at risk for too much heparin, they're getting too much heparin, it's going to be protamine sulfate. The adverse effects from Lovenox are pretty much the same as heparin, hemorrhage, thrombocytopenia, and overdose, and protamine sulfate is the same antidote for Lovenox toxicity as well. These drugs should be used cautiously in patients who have ulcers. Remember, in ulcers, the patients are at risk for bleeding into the GI system. If somebody has severe hypertension, they're already at risk for stroke. So if they're at risk for stroke, they're at risk for bleeding. We don't want to put them at any higher risk for bleeding into their brain. If they have liver or kidney disease, we don't want to put them at higher risk for bleeding. We don't want to give them heparin or a threatened abortion, meaning a high-risk pregnancy that's a threatened abortion. We don't want to put them at risk for bleeding because of that, because that can put mom's life at risk because of that. She can bleed out because of that. Really, the only medication-food interaction is patients who take aspirin or NSAIDs or any other anticoagulant are going to have an increased risk of bleeding because of the additive effect, the additive anticoagulant effect. So the person should not be taking aspirin or other anticoagulants or NSAIDs because of the increased risk of bleeding. So some nursing administration, obviously make sure the patient's, you have an idea of the patient's vital signs. You should have an idea of what their platelet count is, what their baseline CBC is, what their hemoglobin hematocrit is, have an idea of what their basic labs are. You should also know what their PTT is if they're getting heparin. Like I said, Lovenox is not so important. Read the label carefully when we do our labs. The next time we're in lab, we'll talk about the different concentrations of heparin, but you have to read the label carefully because heparin can come in several different concentrations. It can come in 100 units. Oh, and that's another thing. Heparin comes in units, not milligrams. It's measured in units. So it can come in 100 units per milliliter. It can come in 1,000 units per milliliter, or it can come in 10,000 units per milliliter. So it's very important to check the different concentrations because overdoses can happen very easily. This is a high-risk drug, so the calculations must be checked with another nurse before it is given, and that's kind of standard across the board. For LPNs and RNs, the dosages must be checked with another nurse before it's given. For hospitalized patients, when IV heparin is started, the PTTs, those bleeding times, are checked every 4 to 6 hours until the appropriate dose is determined, and then it'll be checked daily because it's that important and it's that high risk. When you're giving it to a patient subcutaneously, the needle is very fine. It's a very small gauge needle. Remember your technique when giving subcutaneous injections. When you're giving heparin subcutaneous, you're using a very fine, thin gauge, a 25 or a 26 gauge needle. You do not aspirate. You're giving it in the abdomen. Here, I'm going to write some of these down for you. Hold on. I just wanted to erase some of that. For sub-Q injections, do not aspirate. Give in the abdomen. 2 inches away from umbilicus. Do not massage. No massage. Let's see. Rotate injection sites. No massage, but apply a gentle pressure after the injection. Remember, P means after, to prevent bleeding. Okay, so just remember those tips. Remind the patient, educate your patient to monitor for bleeding. Bleeding gums, nosebleeds, bruising, abdominal pain, coffee ground emesis. I don't know if you guys are familiar with that term. Coffee ground emesis. Emesis means what somebody vomits up. Coffee ground emesis is blood, is partially digested blood, which just means they're bleeding into their stomach and it's kind of sitting in their stomach, and when they vomit it up, it looks like coffee grounds. And tarry stools, again, that's digested blood, that's old blood that's in their digestive system that's being passed. Instruct your patients to avoid NSAIDs, aspirins, and anything that contains aspirin. Like there are certain combination medicines, for example, Excedrin, migraine contains aspirin, so just be careful and make sure they know what medicines they're taking. Okay, so lots of patient education with these medications, or with with heparin and Lovenox. All right, I'm just going to look at the book real quick, make sure that I covered everything we needed to cover for this. I think that's about it. Make sure you know the normal, the therapeutic range, the 1.5 to 2 times the baseline, the protamine sulfate for overdose, the injection techniques and the patient teaching, the signs of toxicity, heparin-induced thrombocytopenia, and that should about cover it. All right, and the next one we're going to do is the second anticoagulant, which is Coumadin. Okay, so now let's talk for a few minutes about Coumadin or warfarin. Now I'm on Clayton, page 438, 439, ATI book, page 295. Coumadin is kind of the oral or pill form of heparin, although they work a little bit differently. They kind of are given if the patient started on an anticoagulant in the hospital, they're probably going to be discharged on an anticoagulant like Coumadin when they go home. So Coumadin is only given in pill form. It also prevents clotting, but it works a little bit differently. It antagonizes vitamin K. So it works, remember, vitamin K is important in that clotting cascade. So Coumadin works by taking vitamin K out of the clotting cascade. And remember, if you interrupt one part of that clotting mechanism, then the clotting mechanism will not work and the patient won't be able to clot their blood. So we give Coumadin or warfarin to patients who, for example, are at high risk for a thrombus or a clot, for example, with AFib or prosthetic heart valves, patients who maybe have a thrombus that caused an MI or a TIA, remember that's a mini stroke, or a pulmonary embolism where the clot has gone to their lungs. So the adverse effects are similar to that of heparin. Hemorrhage, obviously, increased heart rate, decreased blood pressure, bruising, bleeding gums, petechiae, bruises, hematomas, black tarry stools, all signs of hemorrhage. For heparin, remember, we looked at the blood test called the PTT. For Coumadin now, we're going to look at the lab test called a PT and something called an INR. The PT is called a partial thromboplastin, and an INR is something called an international normalized ratio. And this is going to be standardized across all labs. And it's important to remember the difference between the PT for Coumadin and the PTT for heparin, because the two are different times. But PT, INR go together. That's what we look at for Coumadin. They commonly call them bleeding times, and then the PTT is for heparin. Basically, you're still looking for 1.5 to 2 times the patient's baseline. So that means if the lab values are 1.5 to 2 times the patient's baseline, that means that their Coumadin is therapeutic. If they're more than that, that means their levels are too high, and they're at risk for hemorrhage and bleeding and toxicity and overdose. If they're less than that, then the Coumadin is not going to be effective. So therapeutic doses of Coumadin, you're looking for the PT and the INR to be 1.5 to 2 times the patient's baseline. Hepatitis, again, all this blood clotting stuff is going on in the liver. So it makes sense that hepatitis or inflammation of the liver is one of the adverse side effects. So just like we talked about looking for jaundice, weakness, nausea, muscle weakness, all the things that point to something going on with the liver, look for those, monitor the patient's liver enzymes, looking at their skin, looking for jaundice, those kinds of things. That's what you're looking for the adverse effects. For toxicity and overdose, you're looking for signs of hemorrhage. To treat a toxicity or overdose, we said that Coumadin antagonizes vitamin K, so the treatment or the antidote is vitamin K. We give the patient vitamin K. That's the one to remember. The antidote for an heparin overdose is protamine sulfate. The antidote for a Coumadin overdose is vitamin K. You need to remember that. Okay? That's what you need to remember. Coumadin should not be given in patients with low platelets. They're already at risk for bleeding. So we should not give them Coumadin. That's going to knock out their ability to clot. Should not be given to patients who had surgery, their eye, their brain, or spinal cord. Should not be given to patients with a vitamin K deficiency. They're already going to have problems clotting their blood. We shouldn't give them any more Coumadin. And patients with liver dysfunction or alcoholism, they've already got problems with their liver. We don't want to give them any more issues with their liver. And Coumadin is a pregnancy category X. And pregnancy category X means it has been shown to definitely cause harm to the fetus. There's a high risk of fetal hemorrhage, fetal death, and CNS defects with Coumadin. So do not give it to a pregnant woman. Do not continue to give it if you find out your client is pregnant. Okay? All right, so I'm going to pause here, and then we will talk about medication and food interactions because there's quite a few. I'm going to group these foods and drugs into things that increase the effects of Coumadin and things that decrease the effects of Coumadin. So remember, if something increases the effect of Coumadin, then they, in essence, increase the risk of bleeding. And if something decreases the effects of Coumadin, they increase the risk of clots. Okay? If somebody is taking Coumadin as well as heparin, aspirin, Tylenol, NSAIDs, steroids or glucocorticoids, sulfa drugs, which are a type of antibiotics, cephalosporins, they will all increase the risk of bleeding. Things that will decrease the effects of Coumadin, phenobarb. Remember, that was an anti-seizure medication. Phenobarbital, Tegretol, which was also a anti-seizure medicine. Tegretol, Dilantin, a seizure medication. If you go back and look at the lectures we did on those, you'll probably see these as well, that they decrease the effects of Coumadin. Oral contraceptive. Oral contraceptives and vitamin K, foods high in vitamin K. And just as an aside, your ATI book lists a couple of foods that are high in vitamin K. Dark green leafy veggies like spinach, cabbage, broccoli, Brussels sprouts, mayonnaise. I had no idea mayonnaise had vitamin K in it. I'm going to have to double check that. Canola and soybean oil. Can be eaten by your patient. They don't have to be avoided completely, but they should be avoided in excess because too much vitamin K will inactivate their Coumadin and will decrease the effects of their Coumadin. So just some things to keep in mind when your patient's asking you, some of the things they can eat and some of the things they can't eat. Coumadin is a big deal. They're on it for usually for a long time. If the patient has something like a fib where they're going to have to live with it for the rest of their life, these could be changes that are going to be life-altering, or they may only need to be on it for a few months while they recover from surgery, or maybe for sometimes a year after they've had something like a pulmonary embolism. So it really depends on the patient and why they're taking it. Some things to remember: make sure you tell them to avoid alcohol, avoid taking aspirin. For pain, they should probably wear a medical alert bracelet, letting everyone know if, God forbid, something happens, if they hit their head, if they fall, they're at risk for bleeding, to let medical personnel know that they're taking these kind of drugs. Okay. All right, I'm going to pause here. We have one last classification of drugs, and that's antiplatelets, and those are drugs like aspirin, and then that should wrap up this part of your test. Some quick notes about aspirin, which is the primary antiplatelet that you're going to see. You may also see Plavix, which is another form of, which is another antiplatelet type of drug. Basically, these drugs work by preventing platelets from clumping together. If you remember from A&P, one of the things that happened when the vessels were damaged was the platelets would send off chemicals. They would cause vasospasm, and then they would start to clump together and stick together to form a plug. Aspirin prevents the platelets from clumping together and sticking together, so they prevent that arterial blood clotting. So in that way, they help to prevent clots in cases of, for example, patients having an MI and things like that. So some of the adverse effects. Normally, you may hear of patients taking low-dose aspirin therapy. That's kind of to keep everything running smoothly through the coronary arteries, keeping the blood from sticking to itself as it runs through the arterial system. But it does have some adverse effects. The most common are the GI effects, some nausea, some vomiting, dyspepsia. Remember, dyspepsia is indigestion. But it does cause the antiplatelet effect, which can lead to some serious side effects like hemorrhagic stroke. Hemorrhagic meaning bleeding, stroke, bleeding in the brain. So it can cause hemorrhagic stroke. Prolonged bleeding time. Sorry, my handwriting is getting really bad. You can see it's 1 o'clock in the morning. Prolonged bleeding time or decreased platelet count, thrombocytopenia. And then one of the unique side effects, we haven't seen this with the anticoagulants, is tinnitus, which is a buzzing or ringing in the ears, and hearing loss. That's one of the unique side effects of aspirin toxicity. Aspirin is safe early in pregnancy, but is considered a category D in the 3rd trimester because it will prevent closure of one of those holes in the heart that's supposed to close in the fetal heart. It will prevent that from closing, so it's considered a category D in the 3rd trimester. And it is obviously contraindicated in patients with bleeding disorders, with known bleeding disorders, And thrombocytopenia, obviously you don't want to exacerbate a bleeding disorder that's already there. And it should be used cautiously in patients with peptic ulcer disease, with renal or liver disease. And remember, you should never, ever, ever give children aspirin. And you should not give aspirin to teenagers if they have fever or if they had recent chickenpox, and that's because it can lead to the development of Reye's syndrome, which can be fatal. So never, ever, ever give children aspirin. They can be given Tylenol or Motrin, but never aspirin. Okay, so that wraps it up for this section, and hopefully these notes will help you focus your studies and outline the chapters for you a little bit more easily. Thanks.